This is going to be a little, I don't know, drier, hopefully educational. I will say, anytime I go to a conference, one of the talks I'm always happy to attend is an OCT talk, because I think there's always some pearl, there's some tip that can help out. And so hopefully there's at least a couple things in this. Again, we're just going to talk about just at least what my algorithm is for looking at patients and looking at outputs. We're also going to talk about the role of the comparison to the normative database. I'm grabbing a cough drop. This is not, we're not getting interactive with the patient. I'm not trying to turn into Phil Donahue. Maybe a slightly dated reference for our fourth-year medical student. And then we'll just look at a couple cases. Excuse me. First thing, you need to know your device, okay? We all know the anatomy. We all know what we're measuring when we look at the RNFL. We're following these RNFL bundles. But each of the devices work slightly differently. They're not comparing and not measuring all the same thing. This slide is, as I said, dated. It's from 2015, 2016. But ultimately, you want to know what your device is measuring. I'm sorry. When we look at the RNFL printout, you want to be systematic in how you look at these. So obviously, like any good imaging study, you always want to check the patient identifiers, make sure you're looking at the right patient who's sitting in front of you. Every device has a different signal strength that tells you, is the scan roughly of okay quality or not? You want to look at the raw image, which we often do not do for common artifacts. Then you want to look at the thickness map. and then compare to the normative database, which is usually one of the things we look at first, because it has nice, pretty colors, and it tells us red, yellow, green. We like very straightforward, normal, abnormal indicators. And then ultimately, then you want to check your progression analysis after you know that visit scan is good. So I have a Zeiss. We also have a TopCon. We use both. But most of these examples are from Zeiss. This is a patient you can tell already just from the scan is myopic. But ultimately, we are going to start out looking at, we check the metrics, make sure the signal strength's appropriate. We briefly look at the thickness map just to see, hey, does it look like an okay scan? Any rough abnormalities? In the Zeiss, really this black and white photo helps us look at the quality of the image. Do we see any big floaters, any big distortions, anything that really gets in our way that's going to impact the quality of that image? And then also, then we're going to look at this raw data and then come back and look at the data comparing to the normative database. So what are some common artifacts we deal with? As our medical student training techs probably knows, getting people to do good scans and understanding what they're scanning, people understanding like, oh, I got a signal strength 6 out of 10. I got 9 out of 10. The scan itself can still be garbage, right? And so ultimately, in this case, we look at this left eye, it is very apparent this is a garbage scan. Okay? We know that needs to be repeated. But in reality, if we look at the right eye isn't great either. And that's because it has motion artifact. This is the most common artifact on OCT, and we get this when we see these blood vessels jumping, right? If you have discontinuity in the blood vessels on your image, that tells you there's motion artifact there. That scan needs to be repeated. This data is not valid, okay? At least in this region. Newer machines do try to keep track of, this is why they have tracking software now. It takes the scan longer. Your techs always want to turn it off because they can take the scan faster without it on. But that's why lots of these devices now do have tracking built in to try to minimize motion artifact. Let's take a look at this eye. What do we think about this scan? And I know this is from far away. You get this scan and you say, hey, signal strength a little low, 6 out of 10, but that's okay for Zeiss. That right eye, especially superiorly, looks a little funny. Get down and we look, normative database even says it's a little funny. Don't see any motion artifact. Scan quality looks pretty good. There are no big floaters in the way. But if we zoom in and we look at the raw data, what we don't normally look at, right? These boxes here, these tomograms, you can see that there is actually a very clear segmentation artifact. The device is not picking out the RNFL layers appropriately, okay? It is not identifying the landmarks. So we send this patient back, they get rescanned. We now have a signal strength of 8 out of 10. The segmentation artifact is gone, and now all of a sudden their RNFL looks pretty good, right? So this is a patient who had a thin RNFL strictly from artifact. And I think probably Brian would agree. I imagine in his clinic, you're looking at raw data on your OCTs all the time, right? In glaucoma, we like colors. We got distracted by all this software. We don't look at the raw data as much, but we need to. Now let's look at a couple examples. Is this disease or normal? All right, so what do we think about this eye? Disease or normal? Fourth year med student, disease or normal? So let's run through. We got some areas when we look at the thickness map, right? We're pretty blue, but some good thick tissue, a little blue, good thick tissue. We do have some shadowing, right? A little bit of floaters in there. The Zeiss says, hey, you're a little thin down below. We look at the overall data, and it says, hey, at least in the quadrants, we're normal. We get down to subsectional analysis, and it flags 2 little regions and says, that's abnormal. Well, this is where we say we need to correlate images with the patient. And when you look at the patient, we have a nice Drance hemorrhage. Okay? So this, even though the normative database is not flagging anything, this is a patient with disease. This is RNFL loss in these regions. Now, what about this patient? Very similar setup, right? We have pretty thick tissue. The RNFL deviation map is flagging that there are thin areas. Same thing, we look at the deviation map, or look at the subsectional analysis, it flags the same areas, and it says, hey, this is abnormal. So is this abnormal or normal? Well, let's look at ganglion cell in this patient, normal. Visual fields, normal. And when we look at the very rarely examined RNFL thickness map, right, which is mapping out how their RNFL maps compared to the normative database, okay? If you look at this patient, they have a very normal-looking contour to their RNFL. But what's different about it is it is shifted nasally in both eyes. Okay? And when we look at the quadrant analysis, you see they're normal and then supranormal nasally. And that's the case in the subsectional, right? 153 microns in the supranasal and infranasal quadrant, that's unusual. Okay? But it is a normal variant. This patient just has very nasal insertions of their RNFL bundles. Okay, this is not disease. Now let's go back to that first patient we looked at, myopic. Right? They can do the opposite because this is now very temporal shifting of the RNFL bundles. And we see this in myopic patients not infrequently Because again, we look down at this RNFL thickness map and we see that, again, she has kind of normal peaks, but they are shifted out temporally, and so that throws off the normative database. Okay? So you have to keep in mind the normative database is helpful, but it is comparing it to normals. And if they start off with abnormal eyes, they are going to be abnormal compared to the normative database, right? So abnormal eyes are going to look abnormal. Here's another very myopic patient, and this is what we more commonly see, and we know these are the difficult patients to try to treat and try to manage and monitor. You can just see there are tons of vitreous debris in this patient. You can see the nerves are massively tilted. And ultimately, if you can see, we also have some vitreous adhesions around the nerve head. So ultimately, there is a lot of artifact going in for us to try to monitor the RNFL in these patients. These are the patients where disc photos are going to be helpful, fields, and then macular OCT, hopefully. The limitation, as we know with macular OCT, is that if they have macular pathology, it's going to limit how useful that data is. In these really myopic patients, they frequently have macular pathology. All right, this is our next case. What do we think about this individual? Right, we have some asymmetry. This right eye looks a little different up above. Just like before, we get way down to the subsectional analysis. The RNFL deviation map says, hey, maybe there's something going on up above. What do we think about this patient? Normal, abnormal. This is normal. This is also an anatomic variant, something called a split RNFL bundle. So this is just this patient's RNFL is slightly more divided than average, and they've been stable over years. You're still going to watch them because you can tell this patient has a pretty large optic nerve and some neuroretinal rim changes, so they're still being watched, but they have not progressed over multiple years. Okay? All right, so here we have another example of an RNFL split bundle. Okay? Now what's different about this patient is there's a little bit more asymmetry. And then when we look at this patient's macular and ganglion cell complex, there is some abnormality. Right? That right eye, not only does it have a baseline difference in its anatomy, it does have a difference in its ganglion cell complex. So this patient actually has both a split bundle and has disease. So they have different anatomy, but also happen to have glaucoma. Okay? So if patients have abnormal anatomy, we don't just want to chalk them off and say, oh, you got a weird eye, you're just made that way. Because we've all seen those patients that show up, hey, doc, someone told me 15 years ago my eyes were just made different. I got weird looking nerves. And they show up in your clinic and they got a central island. You're like, well, yeah, you may have had weird looking nerves 15 years ago, but you also have glaucoma, right? So these patients still need to be monitored because, again, since they're abnormal, these are the patients that bounce from doctor to doctor, and they tell their new doc, it says, hey, your eyes look weird, and they tell their new doc, no, I've been told that my entire life. It's always been normal. So they need a home, they need to be watched, they need to be told, you need to be monitored by the same person to make sure that this is really just, that you don't happen to have both glaucoma and weird eyes, right? Those Venn diagrams do overlap in some patients. So what do we think about this case? Obviously, right eye, pretty bad glaucoma, clearly abnormal. Left eye, we look at the normative database, that looks pretty good, right? We got greens, maybe a little yellow. What do we think about that eye? What is abnormal about this eye? Maybe a little tough for y'all to see, but there is a significant amount of vitreous adhesion around the nerve head, okay? And so what this is doing is and it's much more evident in this scan, what this is doing is artificially thickening the RNFL. This patient has advanced glaucoma. They have significant field loss. Their OCT artificially is thickened because of the vitreous traction. Okay? So this is a normal-looking RNFL due to artifact. You can also get this thickening. We get some patients that have a schisis that can float all the way down to their nerve head, and that can give them artificially thickening. They can also fluctuate, those patients, where sometimes the schisis seems to be a little thicker, a little thinner. We also can see this in patients that have posterior uveitis. I know Dr. Dacey was talking. I love seeing Dr. Dacey patients because their RNFL can be changing all the time because of their base level of inflammation or the amount of macular edema they have. All those things can change how thick their RNFL is. You can also get just like the vitreotraction, an epiretinal membrane can do the same thing. If it extends outside the macula and gets around the optic nerve or along the RNFL bundles, you can get that same presence. Now, one of the big questions always is, what do we do with the disc analysis? Everyone puts different stock in this. There are some good research studies that say essentially the disc analysis, it can be helpful for progression monitoring. I will tell you, in my experience, my practice, I do not find it that helpful. And that's because ultimately the device can have hard times consistently marking the same landmarks. Okay, especially myopic patients, it can be difficult for it to keep track of where it's supposed to be. What I do think it is helpful for is this box right here, which is the disc area. So let's look at an example of that. Here's a patient referred over for cup to disc asymmetry as a glaucoma suspect. Okay. Again, the scan quality is good, 10 out of 10. We have no artifact, good quality imaging. And you can see just grossly, these two optic nerves, there's a difference in their cup to disc ratio. But what is also different is the optic nerve head size itself is different. So this right eye, it has an optic disc size of 2.8, and the left eye 2.2. So what I tell patients is we know we're essentially taking the same amount of tissue, and instead of cramming it through a tiny opening, you're sticking it through a bigger opening. Your optic nerve is going to look different, okay? Their ganglion cell was normal, their field's normal. This is an anatomic variant, right? I don't know how many people have one finger that's longer than the other, right? But it's that same idea that you can, although you are symmetrically made, there can be asymmetry in some patients. Okay. Now, what about this optic nerve head? That is I would consider a scary looking optic nerve. A lot of cupping. When we look at this patient, though, this patient had some of the largest optic nerves I've ever seen in my life. Okay. He clocked in at over 4 square millimeters of optic nerve head. It was one of these eyes you looked at and you felt like if you could just reach in there, you could like put your finger in it, right? It was just so large. These patients also need, and we get these patients, right? We see these patients, they have lots of very thin neuroretinal rims. They're concerning. We have to watch them because even though he measures normal compared to the normative database, what we have to keep in mind is, remember, all of these devices, they are comparing based on where this circle scan is. And every device has a circle ring that it's measuring, and that's what it's comparing to the normative database for that machine. What that means is we are now measuring that much closer to the optic nerve head in this patient, so they can measure artificially thick. It's the reverse for myopic patients or patients with really small optic nerves. We're measuring further away from the nerve head, so those patients can be artificially thin. But again, he is now a control to himself, and we're going to scan him and monitor him, comparing him to himself, not to the database. So, when is ganglion cell analysis important? When do we do MAC scans? Early disease is extremely helpful. We saw it in that patient who had the split RNFL bundle. They had RNFL defects they had ganglion cell defects when the RNFL was a little questionable. There are some patients where they can continue to have manageable information that you can get even when they get RNFL that's hit the floor. That's less common, but it's still something to look at. It's clearly helpful in patients with early central defects. And again, if they have an abnormal RNFL anatomy, it's helpful in those patients. But again, if they have macular pathology, you cannot use the ganglion cell analysis to track because they have an unstable area that you're measuring. If they have AMD, they have a history of CME, any of those other elements, they have an ERM, that is not a stable situation. You can't track that because you don't know what's changing, the glaucoma or the macular disease. So once they have abnormal macular pathology, you can't rely on the ganglion cell as helpful. Okay. All these devices now do have progression analysis software. They give you trend analysis. They try to pick out events analysis if there's a notable change. And again, what is a change depends on your machine. Goes back to knowing your device. Here's an example of progression analysis that can show you some limitations to it. Here's a case where the patient first showed up 2015, and it takes the device until 2017 to maybe say there's something going on with the disc. Takes it until 2019 to even say, hey, maybe something abnormal. In 2021 until it says something really abnormal is going on. Why? Visually, we can tell something happened well before 2021, right? Well before the third scan or the last scan. The reason is the baseline. If you look at this scan, most machines will take 2 tests as a baseline image. If there is change between those 2 baselines, it is going to take the machine that much longer to figure out something pathologic is going on. So at least in our clinic, patients get 2 scans the same day. That's their baseline. Okay? Tech just takes 2 scans, boom, boom. That's it. You now have the baseline. If they change in 3 months, you have your baseline to compare to. Okay? If you do a baseline 1 and you don't see them again for a year and do baseline 2, it's just going to take you that much more time to decide if there's progression going on. So have your techs get 2 scans right out of the gate. And this is our last example. This is our post-acute angle closure example. So this is a patient who had an angle closure attack. We did the tap. Oftentimes they will get edematous afterwards, right? You just think about the compression of the high pressure. We now relieve it. They're going to get some edema, some swelling, so they're going to be super thick right afterwards. But look how quickly this RNFL just plummets over the first 3 months, okay? But then it stabilizes out, and it is global. Superior drops, inferior drops. And so if you just took 1 scan, and you took this first scan, you say, oh man, we dodged a bullet. Your RNFL looks pretty good. I think we're going to do pretty good long term. And then you scan them again a year later, you're going to say, what just happened? What happened in this year? But in reality, all you're seeing is injury from the original attack. And so these patients have to be scanned serially until you get that stability. And in reality, what we should do is reset the baseline to all of a sudden say, here's our new baseline, and we're going to monitor you going forward, because it's always going to flag it as abnormal. Okay? But it also shows how important that time frame is to get these patients in and get that attack broken. Again, OCT, RNFL is still kind of the main thing we look at for glaucoma. You cannot forget about the ganglion cell analysis. Both are super vital in ultimately evaluating glaucoma. Again, you just need a systematic approach to make sure that you're following the same protocol each time to avoid kind of common pitfalls and artifacts. You want to look at the raw data. Be mindful that there are limitations comparing to the normative database. Again, abnormal eyes are going to look abnormal no matter what. The patients need to be a control to themselves, and that ultimately OCT is not a one-time test, right? There are patients where it's definitive. We know 100% you have glaucoma. The vast majority, when we get these suspects, these questionable cases, it is not a one-time diagnosis. And then ultimately, we know in a magic world, it fits with everything, but oftentimes it's a little muddled, and we still have to use our clinical judgment. Thank you, and we'll take some questions, I guess, if we got time.
Questions?
A great talk. I was going to ask, you were talking about resetting the OCT baseline at the end there. Mm-hmm. Do you tend to do that with, post SLT or post starting new drops, or what's your protocol there in terms of if a patient's been getting monitored for like 5 years, would you kind of reset at that point?
I think you reset if you've had a significant intervention or a change in their goal IOP. So if you saw progression and you were leaving their IOP at 18 and you said, I need to now get you at 14, and you do something to get them to 14, and they're at that point, I think it's fair to then reset that baseline. If you do surgery, you do an intervention that changes that. 18 is has caused progression. So I think at that point it's fine to change, because what's frustrating is to get that referral back that says, hey, this patient was 22 and we had progression, now you got them to 14 with whatever intervention we did, but they're still progressing. And you get the notes, and it's one visual field and one OCT, and you think, well, you're comparing it to where they were when we know they were progressing. So if you know that you've done an intervention to change it, then I think it's very appropriate to reset the baseline at that point. I don't think if you just said, hey, you're 18 and you progressed and you're still 18, we did an SLT, let's change the baseline, I think then you're just putting yourself behind the curve. But if it does change their baseline IOP goal, then I think it's very appropriate to do so to help you get a better clarity.
Other questions?
How do you reset the baseline?
You just go in, and every machine gives you the option to pick out which scans you want to be the baseline, and you can set that as being their permanent baseline going forward.
Brian, can you have him repeat his question into the mic? We have virtual people listening, and they can't hear you.
Yeah, the question was just how to reset the baseline. So.
Again, that kind of goes back to knowing your machine, because it'll be a little different on everybody's.
Another question here?
Hey, so when you're initially registering a patient, there is a section that allows you to input their refractive error. Does that adjust a normative database for like those highly myopic patients, or not at all?
No.
What's the benefit in that? If you know, I know that's like a technical question.
Actually, I don't know what the benefit is. There's been efforts over the years to try to adjust it. The problem is the normative database is a shockingly small number of patients. So when you think, oh, Zeiss's normative database probably has thousands of patients in it, it's a couple hundred, okay? It is a very small number of patients that fit in the normative database. So the problem then is and they are normal eyes. They are not patients with weird refractions. They're not patients outside of age limits. That's why if a patient's too young, you don't get normative database information. They don't have very old patients. They don't have a very diverse patient population. So there are strong limits to using the normative database as a diagnostic tool.